It, no, now it's streaming live.
Not yet.
Yeah.
Not yet.
It's okay.
So are we ready to go? Or
No,
no?
Yeah.
we'll let you just wait
Done.
for 2 minutes.
We are live. We are live.
Good evening, friends. Welcome to Indian Arthroscopy Society webinar, specially arranged by efforts of Dr. Deepak Chaudhary. This webinar hosts Dr. Freddie Fu, who is a well-known personality in India, and we have seen him doing live surgery demonstrations in our country. We have attended to his orations and lectures and have been keen observing his concepts about anterior cruciate ligament reconstruction. May I ask Dr. Deepak Chaudhary, who is a good friend of Freddie and has been helping us to organize Freddie to talk to us, to give a small brief introduction about he and his practice, followed by Freddie's presentation. Deepak, please.
Thank you, Dr. IPS. We all know that traditionally the single bundle ACL reconstruction technique has been the treatment of choice in ACL surgery. However, these techniques often fail to place the graft in an anatomical position. And though the early short-term results might be good, in long-term, many patients complained of instability and are not able to return to their sporting levels. With this in view, there has been a renewed interest in restoration of the native anatomy of the ACL, and it is believed that each individual has got a specific characteristic as far as his ACL is concerned. And there are differences between the anatomical characteristics of each patient. So with this background in mind, I pleasantly have introduce you to Dr. Freddie Fu. He's an internationally renowned orthopedic surgeon. He's the David Silver Professor and Chairman of the Department of Orthopedic Surgery, University of Pittsburgh. Dr. Fu specializes in sports medicine and serves as the head team physician for the University of Pittsburgh Athletic Department. Dr. Fu's major research interest lies in anatomical ACL reconstruction, clinical outcomes, and bioengineering of sports-related problems. He has been honored with more than 300 professional awards, including the 2014 AAOS Kappa Delta Elizabeth Winston Linear Award, and also in 2016, he was inducted to the AOSSM Hall of Fame. Dr. Freddie Fu, please, we are really honored to have you with us today.
Thank you. Good morning. Thank you so much, and all my friends in India. And I've been to your country multiple times, and I have a very, very good time. And many of you have also visited with me. Now, this is a learning experience. This is 40 years of learning of ACL, and I make a lot of mistakes. So not everything is perfect. So we are not quite there, but like I say, I'm going to share all my experience with you. Let's see. So again, this is my background. If you look at my resume, I did a lot of things in the ACL. Number one in publication in the world. I have a very high H-index score, a lot of grants and many surgery. But the truth is I still have a lot to learn. This is not quite there yet. And we have to keep our mind open. In fact, I have many colleagues in India that can teach me a lot of things about ACL. So a lot to learn still. Now, some interesting follow-up. This is a 35 years follow-up. In fact, it's more than, this is 38 years now. In fact, this lady sent me a note yesterday. 38 years ago, I did an open vascularized patellar tendon graft on her. She did okay. Some arthritic changes. She actually did a 16-mile run yesterday. Email me. Now, I just did her daughter just recently, and the daughter just have a female augmentation. Now, this is another patient I did almost 34 years ago. I started with the extrarticular, which now become popular. But in the 70s, 80s, extrarticular are very common. It doesn't quite work well. I know people now going back. So it fails, and I did an intrarticular ACL on her. You can see at that time I put the screw outside in. And she did well too. And I just did a daughter most recently. And oh, you did Johnson. Okay. So this is actually interesting. This is now arthroscopic surgery. In '86, I start arthroscopic ACL trans-tibial technique. And this is '89. This is a professional player. I did an allograft patellar tendon with bilateral meniscus repair in '89. And he played professional for 14 years, and he's quite well known. And basically, and if you look at the tunnel position, is quite wrong. So you can have a wrong tunnel position, and if you're very good, you can play sports, but you're gonna get wear and tear, as you can see on the X-ray. Now this is interesting. This is a patient and friend of mine, a doctor. He has an ACL and an extrarticular done years ago, and he wrote me. He said, Dr. Fu never do the extrarticular. Look at what happened to my lateral compartment. He had a total knee. So he's actually a practicing orthopedic surgeon, and he know the extrarticular. You know, I know people want to do it right now, but just don't jump into it, okay? So again, you are interested in how to do it, but I'm gonna challenge you. You should ask why and what. Why are we doing this? What is the scientific basis? What our nature look like, okay? Are we changing nature to doing these things? So this is a very important question. Now, this is a definition we have in Pittsburgh. It's important. This is the future of ACL. If you pay attention to this definition, you can improve on your outcome of ACL surgery and in research. So the ACL is dynamic. It's not static. It's biological. There are bundles that work with bone morphology. Now, the bone morphology may be more important than the ACL itself or the ligaments, because it defines the whole kinematics. And because it's a living structure, there's variation, big variation, as well as aging. The ACL age from young to old. So if you're going to use cadaver part to study anatomy, it's not quite right, okay? So you have to operate on young teenage, 25 years old. Now, if you look at this beautiful picture dissected by me and Paul Galano years ago, he passed away. It's beautiful, but this is not true. This is not real. This is a static structure. You look at it. It's beautiful, but it's not really how the ACL behave. The ACL is complex. It's bigger on top, smaller in the middle, and bigger on the bottom. And I think what we want to do in Pittsburgh is to restore the insertion site, 50 to 80%, not 100%. It's hard to do it, okay? Unless you repair it or do something like that. Now, this is a micro CT by Stefano Stefanini to show the complexity of the ACL from top, from the femoral insertion through the mid-substance, and you can see the bundle, the septum start to occur. So this, right there, the septum, you can see the septum is where the blood vessels come in. Look at that, those are the two AM and PL bundle right there. Again, what you think on your left side is a ACL, you think, but on the right side is how the ACL behave. It's like a pumping heart. It's like Henry Mencken say the cartilage squeeze together and come apart. It's not like a chondral site and active. It's a very active structure. Now, we just proved it by putting a cadaver part on a robot and move to the 6 degrees of freedom and use the laser scan. You can see the shape and size of the ACL change drastically by this motion. So don't describe the ACL as a specific, thin layer or ribbon or something like that. This is changing or if it's changing. So a bundle is a good description because it's always change. Now, if you're gonna go to a lab like this is a $3.6 million machine that you can see everything about the knee. Is the EKG of the knee. We can measure the intra-distance of the insertion site as you run. Now, you'll be surprised to hear that when you run, the ACL squeeze together and pull apart about 20 to 30%. They squeeze together. Why is it squeezed together? Because it allows the blood supply to come in. It fall apart and prevent it from being torn. Of course, we know the 8% failure rate, but you do know that the ACL actually come together. And this is important. So it's really dynamic. It's like the heart pumping. So the concept of isometry is completely wrong. It doesn't exist, okay? Now again, people talk about direct and indirect fibro. Now for this 20 to 30% motion to occur, you need all the fibers to work. If you only have direct fibro, the ACL will tear very quickly. You need the indirect fiber to allow the giving to 20, 30% to allow it to have this dynamic, elastic property. So again, don't think about static. If you think about static, it's okay. in the laboratory, but in real life, it's a very dynamic structure. Now let's go on biological. Why are those bundles? At one time, we thought the bundles are there for a biomechanic reason. It's true in some way, but as you know, all ACLs are torn in one big bundle. Anyway, it's not like there's some partial tear sometimes, one bundle tear about 5–6%. But most of the time, the ACL is torn in one bundle. So I asked the question, why are there two bundles here? Now the answer is biological. There's membrane coming from the meniscus to the ACL, and the membrane will form septums. And the septum to divide the ACL into bundles. Two bundles, human being, animal-free bundles. And what we find in the laboratory with Dr. Hewitt years ago is that we actually look at fetus as well as patient we operate on. And within that septum, right here, beautiful septum, there's stem cells, there's nerve, and this is where your lifeline of the ACL come in. Every time you run and play sport, you play cricket, the ACL squeeze together and come apart. And when they squeeze together, the blood will come in and revascularize the whole ACL, and stem cell will come in to, heal things that's torn, and it will come apart, the blood supply will be gone. So it's a cyclic thing. And like I say, we find the stem cells in there, and you can see it's a beautiful vasculature right there. You can see the vascularity right there coming in. Now this vascularity is nothing new. Anaski to show that this is a lateral meniscus vascularity on the peripheral, and this is the important vascularity near the anterior horn of the meniscus is right here where the blood supply come in. Of course, on top, it comes from the lateral genetical artery. So this is a lifeline. And you can see this is beautiful, beautiful vascularity right there. You can see vascularity right there. All the vasculature coming in. The septum right here between the two bundles. And if you cut the stump with a knife, you can see this blood's coming in right there. So in surgery, we save this part quite a bit. Now you understand the ACL and the lateral meniscus anterior horn overlap about 35% with indirect fibers. All the structure within the knee talk to each other, just like I'm talking to you, okay? They are not like isolated. So this is why, you have to think big. You have to think more than an ACL. ACL talk to the meniscus, talk to, the P-cell, everything. Now, this is an incredible study over the years, took 20 years. So this is the fetus. We did fresh fetus, 1 day old, and you can see the vascularity from meniscus come here right there. And we have 150 of this specimen over the last 20 years. This is a 17 years old. You can see the vascularity, same vascularity coming in and divide the ACL into two bundles right there. Now this is, after I cut, you can see the blood vessels coming in right there. And this is maybe my ACL. I'm 69 years old, by the way, I'm an old man. So when you're old like that, the vascularity has disappeared. Like you're losing your hair or getting white, okay? And in fact, you get degenerative changes, mostly of the PL bundle, get fatty changes right here. So you can see how it works. Now, actually, recently, we have to use ultrasound. This is a new ultrasound machine that can look at vascularity. So we look at vascularity of these bundles. We look at healing of the ACL, for example. When you put a graft in the first month, it's become highly vascularized compared to the normal side. And with time, the vascularity diminish over the next year. So this is another way to look at vascularity, healing, and elastic property. Look at that. These are nice, bundles, vascularity between the bundles right here. Now, so this is a first fetus we did, fresh fetus. You can see the two bundles right there, vascularity, coming in. And this is a 30 years old. And this is 18 years old arthroscopic meniscectomy cases. You can see a very big PL bundle here. And in America, the rest of the world, they do not like this PL bundle. They think it's not important. But I believe in nature. Nature tell me everything is important. Okay? If you're going to damage nature, you cannot get it back. Just like we damage the pollution, everything. When you do it, it takes 100 years to come back. Remember in India that American company do chemical spill or air to kill many people. Horrible, horrible. This is exactly, if you ignore this, look at nature. Don't create nature. Don't make things up, okay? Now this is ACL. I did this a long time ago too. This is AM bundle PL. Now what is important about this PL bundle? It doesn't control rotation. The PL bundle actually allow rotation when it relaxes at 90 degrees. And the rotation depends on the bony morphology. Okay? So some knee can rotate at 9 degrees, only 9 degrees. Some rotate 27 degrees. So it's a big differences. And you can see this is vascularity here between the bundle. Beautiful vessels right here. One bundle tear, you can see AM and syntax is occur about 6-7% of the cases. Most ACLs are complete ACL tear. Now this is important study. We did two of this, one about 25 years ago and one more recently, using robotic technology. Essentially what you do is if you're gonna restore the ACL in a robotic technology with two bundles right here, two things happen. You're gonna restore the kinematics, you know that, but you also restore incidental forces. Do you understand what it means? Now, you understand, if you're gonna have a tie of the car not balanced, the car won't drive well. But if you're gonna restore the ACL in the wrong place, the ACL will not restore the incidental forces. In other words, the force of the ACL will be less in an abnormal position. And the force will be shared by the meniscus cartilage more. And as a result, you're going to get wear and tear. And this is a good example. This is my patient I did almost 25 years ago, is a trans-tibial vertical graft. And this healed fine because the notch is big enough. But this patient, luckily, she is a lady that plays tennis once a month, have some mild degenerative changes. But this is a really wrong position of the ACL, and the load will be shared by the meniscus. But if you're going to be very active, you're going to wear the knee out very quickly. Now, this is anatomical reconstruction. You can see right here. You can measure the angle. The angle should be less than 57 degrees. 43 to 57 is, this is almost like 80 degrees, okay? Now, if you're going to do this surgery, anatomical, if you allow the patient to go back too early without healing, the ACL may tear because now the incidental force return to normal. So if you're going to do anatomical reconstruction, it's not just a technique, not just how, but you need to think of the whole strategy. Double bundle, anatomical, all those things take longer to heal. 6 months, many times, are not enough. You need 9 months, 1 year to be better. Now, the other thing about knee is the bony morphology, which I think is a big secret that we have to learn about. Not just two-dimensional, we have tibial slope, but three-dimensional. And this is Loven Lovejoy, who discovered Lucy in Africa. This is Lucy bone, and you can see Lucy has a resin ridge. This is Lucy ACL. This is a 3.2 million, cadaver, that essentially can walk upright. And this is modern human being with AM and PO bundle too. This is resin ridge. And this is the bifurcate ridge we discovered in Pittsburgh. And animals are interesting. This is a bear. I took this myself. You can see the shifting. Boom! Look at that. Look at the pivot shift in the bear. Boom! Look at that. So essentially, when the bear go to sleep and examine by the zookeeper, we go and examine. We did 38 species of animal. I will come to India to look at the elephant too. If you want me to, we look at it, and when they die, we actually take the bony morphology and look at it. See what happens. So this is a mentro monkey. This is a torn PL bundle in the mentro monkey. AM and intermediate bundle. There are 3 bundles in a monkey in a very big rotation with a torn, monkey. We have many people here, operate on him. And this is lion, polar bear, cotton top monkey, and tiger. And when they go to sleep every 5-10 years, we examine them. And when they die, and this is a dog. This is a very high TPS of 30 degrees. And they have a very unstable knee when you turn the ACL. In fact, develop arthritis within 6 weeks. So the tibial slope 3-dimensional is another indicator for not just instability, but for developing arthritis changes too. Now, so when these animals die in the Pittsburgh Zoo, another place in the world, we harvest the bone. We look at the ACL, morphology of the bone. You can see very different. Look at the bear, very narrow notch. And look at how big the meniscus are. Look at that, how big. They need much bigger than we are, okay? So then we can look at all the structures and look at the motion and understand. So I'm going to tell you, the ligament is nothing. The ligament is just there to help the bony morphology to move, okay? We must understand the basic, which is the bony morphology. Before you do an ALL or extraticular, you have to see how the bony morphology rotate the knee first, not just the shifting, okay? There are many things we don't know. We just want to operate, okay? Look at that, morphology on the 3D CAT scan, you can see that. You can see that beautiful insertion site, AM, intermediate, and PL, and look at that. It's really specific. For people in Europe, like from Poland, people say they have no bundle. It's so totally silly. Bundle has been there for millions of years in the animal and in the human coming. If you don't think there's bundle, it's bundle because of both biomechanic and biological reasons. So another animal, look at that, 3 bundles right there. Now also, you heard about ALL. I gotta tell you, it doesn't exist. This is the lemur. This is the only primate, the lowest primate, that have a bilateral collateral ligament system. In other words, after the lemur, if you go to gorilla, chimpanzee, they do not have a 2 ligament system anymore. The bony morphology do not require you to have this 2 ligament strap system. The IT band is important. So if the IT band is intact, the capsule is thin. If you want to make the capsule a ALL, you just create a ligament. It's create nature. It's not a real nature. Okay, so this is a real nature. We have 38 species of animal to prove it. Now this is human being, 2 bundles. This is gorilla, 3 bundles. And some human being also have 3 bundles. Okay, you can see the vascularity coming from the lateral meniscus, right here. And then you supplied it through the, let's apply. Bony morphology. Now, by the way, the size of the patient had nothing to do with the size of the insertion of the ACL. Some tiny little girl, 5 foot, has a big insertion site than a 6'5" football player in America, because I measured thousands of them. All right, so it depends on the bony morphology. If you require more rotation, you probably have a big insertion site and a bigger ACL. So this is human, this is, gorilla, and you can see the motion are different. Look at that. The medial femoral condyle of this required so they can move. And human being variation is from 9 to 27 degrees, big variation. Again, if you look at every ACL, they're different. There are no 2 ACLs the same. It's like your fingerprint, okay? Everyone is the same. It's not the same, okay? If you know to make it the same, you're gonna do about 70% success. And this is why, if you look at this variation, you can correct this, you're gonna gain 15% of your ACL results. You don't have to do all those crazy things people are talking about. Now, sometimes you have to do something, but if you're gonna follow this principle, variation, and understand it, then you can make many corrections that you do not really need to do other things. Just take care of the ACL first. Do the best job at the ACL. Now, this is a long, narrow notch. By definition, the ACL will be long and narrow. Okay, so if you want to do a bigger ACL, bigger than 10 millimeters across, it may not have enough room, and you're gonna lose motion. This is a very big notch. And you can see this is a big oval shape. By the way, it's not true the ACL is a C-shape structure. Only in 80-year-old cadavers. This is how the ACL look like. We cut it in a young cadaverous, actually not cadaver, but a real ACL surgery. Okay, so this is a really good size ACL right there. This is the AM part, and this is the PL part. Variation is the key in life. If you can measure on the MI, the variation is 3 times differences on the surgical plane. Some are as small as 8, Some are as big as 26. And this is all published in HASM almost 10 years ago. Recently, we've measured in 3-dimensional. We have 3 cuts on sagittal and 3 cuts on coronal. And all you measured during surgery in hundreds, thousands of patients. And this is a graph we use. So if you are in this range, you shouldn't do a double bundle because it's too small. Here, you may. This, you can argue whether you want to do it, okay? So essentially, single bundle works well too. So not just double bundle. So, but indication is the key. Find the right indication. Don't do in every cases. Find the right case to do. So again, this is a beautiful stump. You may argue you can repair it or augment it, but this is how the ACL look like. Look at that, beautiful. Don't believe all those articles. Say this is a sheath structure, this is direct fiber, this is no bundle. Come on. This is, you can see this is the damn ACL right here. Come on, you can do it tomorrow in your surgery. Another one, you can see, every time I do this thing age, this is what you're gonna see. Every time, look at that, beautiful, beautiful oval shaped structure right there. And people just say, oh yeah, let's just do this part. Let's do the direct fibrous isometric surgery right here. This is silly. How about all this thing? You ignore it completely, okay? And this is why you fail, about 15%. Variation, look at that. All the insertion site. What's the time? Yeah, all the insertion site. All right. Okay, you look at it, beautiful insertion site. And this is, look at that, all the femoral site. Now, by the way, this one is a QA function. Probably can repair. Look at that. This is direct and direct fiber all together. They're all important. This is oval shape, and this is more like a round shape. So you cannot do the same thing. So if you're gonna do a 10 drill on this one, it may be too big. You need to do a more smaller drill, maybe a double bundle in these cases. All right? This one, you can probably do a very big drill. And you sometimes just ACL smile at you too. Again, I'm holding on the PL bundle right now, so strong. Look at that, the PL bundle, look at that. Direct and direct fiber all together. This is AM, this is PL. I don't know why people say this is not important. God gave it to us. All important, nature, all important, okay? Look at another one. This is the PL bundle. It's bigger than the AM, this one too, okay, this one. So everyone is different. If you look at this variation, and people, oh, there, let's just do the AM right here, you know, the isometric direct fiber operation. Look at that, the PL is bigger than the AM in this case. So if you start looking at this variation, you can now tailor your operation exactly what you need to do. Look at that, this is a small notch, low notch, 11 meters. I have seen almost 100 of this patient refer to me for revision. People do a BTP in America, they love BTP. It doesn't work because it's too big, okay? You look at that. And this is done actually in New York City, famous place, done 2 times. Many of them 2 times. They put a 10 BTP and then put an 11 allograft BTP on, both fail. Now look at this, this is my own patient. Look at that, you can put it in the wrong place. It doesn't matter because your notch is so big. And these are the things that will result in arthritic changes in the knee later because basically you put the ACL in the wrong place. Again, we like to restore 50 to 80% of the tibial side. Why 50 to 80? Because if it is more less than 50, it's probably too weak. Now, why 50? Because sometimes the graft size is not big enough. Okay, this is why we're gonna do some measurement on the graft size to know. And this is why 80? Because if you're more than 80, then it won't be enough room, for example. I mean, there's no room, you lose motion. So somewhere in between, ideally, I like to do 70 to 80%, of course, if you can repair it. So if the insertion site and tibial here, the graft can be a little smaller. By the way, every graft you put in will hypertrophy, will get bigger and remodel, become 2 bundles per time. Again, this is too small graft right here. On the CAT scan, this is very big insertion site. Only 30% of the insertion site, it fails in 6 months. The first time she kick a ball, and this is fine. This is about, 80% right here. Again, you can do pre-op measurement. Very simple. Look at that. With the MI, you can see the size of the quad tendon. You can size of the patella thickness too. If you have a trail thickness, you do a PTP, you may fracture the patella. You can also measure the length of the quad tendon, also the thickness. Look at that. You can see the ACL, torn ACL right here. You can see the size right here. So you can compare pre-op, and you can use ultrasound. I do ultrasound on every cases now for the last 6 years. High quality ultrasound compared to normal size. You can see the size of the hamstring tendon. You can see the size of the quad tendon. And with that, we can actually calculate. We actually publish a paper already to show the size. We should show that, you know, the size. Okay. So when patient came to see me, before I operate, I already know the size of the, you know, patella tendon, quad tendon, the length, and I also know the patient length size, and I try to match the graft to the right size. So for example, this is a double bundle right here. This is, right, you can see AM and PL. This is a one bundle tear on the MI. This is one bundle tear right here. This is one bundle AM tear right here. This is the ACL mid-substance tear, AM and PL right there. This is, which one is a complete tear? Can you tell? You cannot tell, right? Because you don't have this special cut. If you special cut, oblique cut, you can see this is a partial tear. This is intact here, and this is a complete tear, okay? So essentially, this one is more stable, and this one actually can heal without surgery. You can see it heals up pretty good. This is tear. It may be hemorrhage. Patient is stable. MI repeat 4 months later to show that 6 months later show that it's healed. Again, this is a partial tear. Let it heal. Take about 1 year. So it can heal in a small percentage of time. Not too many, but you have to look at cases. People want to get healing. Another one, look and see the healing occurs. This is interesting. This is an Indian guy, a PhD student at Pitt. He came to see me 35 years, or maybe you guys have more potent stem cells. And you say, oh, well, I'm busy doing my PhD. I won't have time to operate. She's very unstable, very unstable. But he came back 1 year later. Look at that. The whole thing is healed up, my God. So healing can occur, but not many, many cases. You think about it. So think outside of the boxes. Just don't look at ACL. Look at beyond the ACL. Look at the bone morphology, meniscus, nerve fibers, alignment, everything to make it work. Aging. Now this is young, this is old. Xavier Wu in 1991 showed that this is a 5-time difference in the strength, 5 times. This is a fetus, 2 bundles, 30 years old, this is 80 years old. And this is what you read about in the literature. The literature say that, hey, your strength like that, there's no bundle, there's seizure structure, but it's wrong because the PL bundle is all fatty changes. You cut it out, you become a bundle, a ribbon or seizure structure. These are all the studies done, and remember, this is our NIH study. The age is 21 years old. These are all 180 years old. So you cannot believe that all this. They're good people. Don't get me wrong. They're very good, but all the specimens are old. So you cannot use this to conclude in your surgery. How? Okay. Why? Because why they're younger people, they're different. You can look at younger people doing surgery. These are 2 of my Japanese fellows. One of them is Erie. He's a very good guy, no hair. This is only the AM bundle probably. This is PL is all gone. This guy has all the hair, direct and indirect fibers right here. This is, Akira. Look at that. This is all there. So everybody is different. Age is different. So we do all the study. I call it fragile anatomical study because we want to do a one-size-fits-all surgery, easy surgery. The company say, oh, let's do this. Let's do the ALL, and let's do internal bracing. Let's do a tibial slope. Well, it is. Many times you don't need to do it. If you look at what I just told you, you're going to correct 15% of your mistakes right there, okay? Because I revised more than 2,000 ACL over the world. And I'm telling you, if I look at all those things I just told you, I can correct 95% of that. In some cases, I may have to do extraarticular tibial slope. But most of the time, I do not have to do that. Again, this is all the graft choice, and this are all the other possibility. And this is, by the way, this is a 2 years old hamstring cases. The bundle has reformed, the vascularity is right there. It's a beautiful. So again, we insert 50 to 80% and let it heal. It's a concept now, double bundle. It's not just a, technique. Individualized anatomical. And why is value-based? Because you just pay attention to the ACL. Your measurement doesn't cost any money. Doesn't cost any money for getting devices, artificial ligament, all this kind of thing, okay? These are all cheap. It's all there. In fact, my technique haven't changed for 30 years, basically. Okay, the technical part, I can do the surgery very cheap. By the way, this is a 21 years old follow-up of the PTP. You can see the two bundle reform, vascularity right in the middle, right here. Okay, anything you put in, let it heal, it will reform. God will take it naturally back to where it belongs. Again, with this kind of measurement, pre and doing surgery, you can pick the surgery you want to do. I do mostly single bundle now. I do about 10, 15% double bundle. I do some augmentation, maybe about 6, 7%. Preservation, you can do more and more now. The Japanese, Korean is very good. Repair is something new, but don't get into the habit of repairing like the company tell you. They're not repairing. They're putting a device, putting a drill hole. Repair means that you sew it and put it to the insertion site directly. That is a repair, usually with some fibrin clot and non-operative. And all those cases should be individualized rehab. So if you're gonna do this, ACL is fun again. Let's make ACL great again. It can be applied for 100% ACL surgery. Every case is different, ladies and gentlemen. I used to be, do many cases. Yeah, so again, you can see 6-month post-op on the left, and this is the normal side. And I did a pretty good job right there. You can measure it yourself. One size fit all, you will miss about 15%. And this is why all of us say, wow, I do this and I 15%. This is why I need to do, extraticular depth. I'm going to do this and that repaired. You don't, you just look at anatomy and you can fix all this variation. Anatomical, individualized, value-based, and value-based, put it on. So essentially, the definition is we can restore insertion site the best we can. The native dimension, culture, orientation, biological will take care of it. Again, this is a single bundle, small, 12.6, beautiful insertion site. You can see right there, 75, 65% MI. You can see CAT scan right there. This is a very small ACL. Small, look at that, the arrow right there. This is only 6 millimeters, 80%. So we did a 6 millimeter graft. We make it smaller. Look at the MI and look at her motion. You get minus 15 hyperextension. If you put an 8 in, she will not get her hyperextension back. She's now 5 years post-op, no problem. This is a very big ACL, very big size. Look at it right here. So we did a big single bundle 11.5 quad tendon here, quad tendon. And you can see, and this is another big one, double bundle with a hamstring, double bundle right here. And you can see the CAT scan, 61%. This is a one bundle augmentation. AM is torn. AM is intact, PL is torn. And you can see right there. And you can see post-op. By the way, this has to heal together. AM and PL need to heal together. You need to let it heal. If you're going to go back too fast, it may return it. You can see the healing. One bundle, 2 weeks, 4 months. Vascularity, 1 year, 3 years. Again, this is preservation. You can do remnant preservation right there. And you can repair in some cases. I think about only a few percent can be repaired. Don't let company push you to repair cases. This is repair, real repair. With a device, with a drill hole is not repair. May as well do a graft. Okay, be 100% ACL surgeon. Now we published some important article. Level 1, level 2, level 1. 15 years, almost 400 patients with very good results. This is a $3.5 million NIH funded study too. So essentially, free prospective randomized study, 450 young athletes over 15 years, less than 5% graft failures, and very good result. So this is what you're gonna do. If you look at the Japanese, same, 5%. So if you look at other people, say, oh, I have 15% failure. I'm gonna do some other surgery. I'm gonna do extraarticular, I'm gonna do AL, I'm gonna do all this crazy thing. You can do it, but I'm already there. So why you have to do all the things? You don't need to, okay? So you have a scoring system for ACL to look at this article. So you can tell how good you are anatomically too. Now, we just recently did a study to look using this system to look at 10 years follow-up on many studies. So if you do anatomical reconstruction, you have much less arthritic changes, than if you do non-anatomical reconstruction. So arthritic changes come from many forms, from trauma, biological, kinematic, genetics. But I think doing the wrong ACL anatomically will predispose you to arthritic changes. Again, with this kind of machine, we can look at it, and I'm lucky to have this $3.5 million machine. So I know a lot about, kinematics, elongation, contact stress if I do the wrong ACL. This study is in Duke, showed that if you do the ACL not anatomically, at 1 year, the free TMI show more thinning already compared to the anatomical and anatomical one. And again, we can look inside the ACL now, beside the ACL, the meniscus, the cartilage with a machine. And this is another study we showed that if you do anatomical, it's almost chondroprotective. The cartilage at 2 years remain the same or even thicker in about 10% of the cases. Again, the left and the right is the same. And one time we thought we can use the left and the right to compare sizes. But we now have this study, NIH study, to show the CAT scan, the left and the right is overlap 85%, not 100%. Now, you know this guy, Kilon Pollock, he is a big star in your country. Now, I operated on him, he came back at 3 months, which is ridiculous. He did. At 5 months, he had this play of the century. And I repaired the meniscus too. But he did on his own. He didn't ask me. So the next ACL 3 years later, he wait 5 months. I say, thank you. But he is a super athlete, understand? Super, super, super. So it's not like a regular person you do. Healing takes time, okay? You can see it's 6 months, the graft may not heal quite yet. So you need about 1 year and even 2 years, people think. Look at the healing. Red is healing. It takes a long time. Maybe 50% of healing before you can play. We don't know. So again, anatomical individualized is important. So anatomy is important, but there's difference. You cannot do the same every time. If you do the same every time, one size fits all, then you're not individualizing. Value-based, because if you look at this two thing, then you don't need to do all this other operation. You don't need to waste money, waste time. Fix the ACL. The knee is the only joint in the body that have a cruciate ligament and allow you to rotate. All these others are secondary importance. Look at the finger. The finger have no rotation. Or the extraarticular is not that important, okay? So for the extraarticular, the IT band is some role, but otherwise, the ACL, pre-cell is more important. So medicine is an art, scientific principle, work with nature, and be critical on your outcome measurement. Don't swing too far. Suddenly now in America, they like to repair, they like to do extraarticular, which is okay, do some, a few percentage, but the ACL is the mainstay. Do the ACL correctly, the best you can. Do it first. Like I thought of anatomy 25 years ago, and when I opened my eyes, there's so many things to learn, incredible. Respect and preserve nature is important. So respect the past, then we can embrace the future. So look at all the studies done 100 years ago. They're all important. Look at nature, don't create nature. Like the AL is a capsule, but now it's become a ligament. People talk about it. The IT band is the most strongest structure on the outside. When you do a lot of multi-ligament, you don't repair the ALL, you just repair, all this damaged part, okay? So at the end, the ACL is dynamic, is biological. There's bundles that work with bone morphology. And because there's nature, there's variations and aging. So if you follow those 5, 6 principles, think about it, work on it, do research on it, you will improve the outcome of ACL. So if you don't remember anything, take the picture of this slide. This slide is most important. I've been in this group called the ACL study group for almost 40 years. And they talk about the same thing in the last 34 years. They start with extrarticular, intrarticular, hamstring graft, artificial ligament, BTB, now quad tendon, now back to extrarticular, now to go to internal brain. My God, they haven't changed anything. They're talking about the same thing. But if you look at all those things I'm telling you about, then you're going to make a differences. Okay? You're going to make a differences, not doing the same thing, repeat and repeat again, and make mistakes again and repeat, going to the same thing again. So this is a wasting time. Technique is a wasting time. Principle is not. The technique only comes from sound scientific principle. Now, lastly, you're going to credit the patient, just like Kieran Pollock. He is so good. Look at Zlatan. He is so good. I did his ACL and posterior lateral corner is fine. And this is about 11 months. So super, and look at how he play. Look at, my God, this is only he can do it in the world. Nobody else can make that kick, I think. So I think I operate on him with Dr. Volker Marcel. I give myself 10% credit, okay? I give the therapist 40% credit. And I give Zlatan and Pollock 50% of the credit. Learning is forever. So thank you so much. I hope that will, make you think and make you do the ACL better. Thank you. Thank you very much. You going to show me double bundle? Deepak, you say?
Thank you, Freddie. I mean, it was an amazing talk, your history and how you actually, over 40 years, your experience regarding ACL reconstruction. Freddie, a lot of questions coming up in here. And the first question which comes to you is, on an MRI, can you predict that this ACL is going to heal and this is not going to heal? So a couple of ACLs you said would heal.
You mean for the acute tone? No, you cannot predict. You cannot predict.
So no predictors.
No.
Okay.
I think, is not the MRI. The healing is biological. So there are two forces. We know there's stem cells through the vessels coming in. We know that, okay? But also we know that there's cytokines. When you turn the ACL, the level of cytokines are really high. In fact, I am, Pasler in the early 90s did 100 German patients. And we find that when you turn the ACL, when you draw the blood, we do it 4 times. Before surgery, during surgery, 2 weeks, and 6 months. The cytokine level is real high. The cytokine are what that will prevent healing occurs. So it's a balance between cytokines versus the stem cells. And we do not know which patient will have better stem cells or better, more harmful cytokines. We do not know. So it's nothing to do with MRI. Now, MRI will give you some mechanical structural property that will help, okay? So if you have some mechanical property that will allow that to heal to occur, that's good. So there's a good start. Like I told you, there's a 1 bundle tear. So and the examination is quite stable. That is a good start. Then you can, but the patient will be on crutches for 2 months. He cannot walk around crazy, but so you have to talk to the patient. They cannot just, run around like that, okay? Good.
Great. Another great question here, Freddie. They say that, in your presentation, you did some ACL single bundle. And you said there was a leash of vessel and there was it started behaving like a double bundle.
Yeah,
Yeah.
so
why do you do double bundle then?
See the bundle. 20 years ago, we are all stuck. I did a study 25 years ago on double bundle, and everybody's stuck on that biomechanic study. Biomechanic is a static study. I'm so sorry. In the 90s, everybody is Frank Noyes, biomechanics, which is okay. But the real life is biological, is kinematics, okay? So whatever you put in, a percentage of the insertion site you put in, remember I told you 50 to 80. Whatever you put in, single or double bundle, the bundle, if you allow the time to heal, it will reform the 2 bundle. It will reform it because the ACL have to survive, have to live. the blood supply have to come in. So the key is if the insertion is big enough, then you can put 2 bundle in. So restore the insertion site. And of course, I think the 2 bundle will allow a better mechanical arrangement too, compared to the single. But I think that also I told you, any bundle you put in single or double, it will hypertrophy. It will get bigger. So a single bundle will get bigger with time. So a flat patellar tendon graft will become round, with time, okay? Yeah. So you can let it heal, not too fast. Six months may not be enough. So the bundle is an interesting idea, but you have to understand the bundle about the anatomy. But biologically, you understand that we're going to restore the insertion site. And with that, and allow the healing to occur, anything will reform naturally what God gave you, okay?
Freddie, suppose you have a high-level athlete who has done a previous ACL reconstruction, and he comes and he has got good stability in the anteroposterior plane, but on pivoting he gets instability. So in such cases, would you do a extra articular tenodesis or go and augment with a PL bundle?
Well, we don't know. Like I say, you have to do studies. You look at alignment, look at X-ray, look at MRI, CAT scan, measurement. So you come up with a idea. So for example, if the insertion site is very big and the patient has a small graft, then you may augment it. And I did it, in about 5%. But if the tunnel is in the wrong position, you may take it out. Now, if everything is perfect, you may do the extraticular, and I do it about maybe 3% of cases, not too many. So I mean, you have to look at and usually if the IT band is intact, I tend not to do too much too. You have to look at IT band. If the IT band is definitely a damage, a signal on the ultrasound or MRI, I would definitely think of doing extraticular too. So again, most of the capsular structure will heal itself. Of course, you have to look at meniscus. If there's a root tear, all the thing, or the root tear can cause instability too. So you may need a meniscus transplant. And how about alignment? If the alignment is not good, maybe a tibial slope sometimes is too high, you may need to think about it. Not that you should do it right away, because I think by changing the slope on one side and leaving the other side normal, you may have a hard time running too as a good athlete. So it's not as simple. The kinematic will change, okay? Now, the other thing I want to tell you, go ahead.
Yeah, is those patients which have got Segon sign, which is positive, would you do an extra articular?
No, absolutely not. I've studied, look at my article on Segon. There are now 3 or 4 articles came out. People with a Segon fracture, number one, do you know how it occurs? I can give you another talk on ALL, With this scaphoid, Segon occurs only when you turn the ACL. It's a 2 mechanism. First, you have to turn the ACL first. And second thing, you have to bend the knee, flex it, and then rotate it. So the Segon only occur in a small percentage because it needs the ACL to be subluxed anteriorly, the tibial, and when the knee flex interrotated, then the Segon occur. Now, I have 15 patients I follow, and the patient actually told me this is exactly what happened about 5 years ago. She told me, hey, I was playing football. I turned, I feel a pop, and I just fall down. And I fall down, I feel a second pop on the outside and then internal. And I saw the videotape. So now I have almost 15 patients, all the same. You have to have 2 mechanisms. Now, why? Because when you flex and rotate, the IT band, the capsule become tight. In 30 degrees, that lateral structure is loose. I'm going to show you go to VMedi, look at my thing. So statistically, too, and I have a case then 2 Segon. Now, by the way, Segon fracture is 3 things, not 1 thing. Either it's a capsule, it's described by Segon, and also it's an IT band. Posterior IT band is described by Moret in France. And now we've described 1 more. We have 2 cases, the superior bicep is involved. So it depends on how big the Segon fracture is. So the top part is a capsule, this is the IT band, this is the bicep. And I have a case, only in the world probably, maybe more in the world. I have 2 Segon. One is that, now I do ultrasound on everyone. MRI ultrasound, and I can open it up and look at it. You don't have to repair it because it's so little to repair. It's so tiny. You push it back with a finger. You don't need it, 1 sutures and that's it. And one case I have two Zigon. One is a capsule, one is IT band. So no question, there's no ALL. There's capsule, there's IT band, there's bicep. If you want to call all the structure combined as AL, that's fine. But those are all described in the past by other people. This is why I'm saying respect the past. Don't invent something that you created and say, you look at me. I never invent anything. Freddie Fu never invent one thing. Zero. Why? Because this is God. Nature give all things to us. I just observe it. Okay? I just thank God give it to me, and I'm going to use it. Okay?
You are changing the entire concepts which we had, Freddie.
What?
You're putting, these are new eye openings actually, because we always treat it some differently actually.
That's fine. It's okay. I learned from you. But like I say, So
when do you do an extra articular augmentation then? I mean, that was
there's IT band compromise. There's IT band. I mean, all those people talk about, I have 15% failure. That's why I want to do it, in the young people. Look at that. I have young people too. You mean the Pittsburgh young people are not as good as the outside people? Of course, the same, the young people. So I have 450 over 15 years. That was study. And I just do the ACL, the good I can, I show you to you, and you don't have to do all those things, okay? And if you're damaged on IT band, I would do something about it in a few percentage. But if there's no damage, also I didn't tell you, I look at every cases with ultrasound, I follow them up with healing. All these capsule tear are healed, they heal. And all of that, I look at with a scope, you can look at the AL area, so-called, there's never hemorrhage. If you see the MCL tear, there's always hemorrhage, okay? Grade 2, grade 3. Look, next time, look at it. Grow it out.
So which means primarily you're not going to do any extra articular unless and until it does not heal and a patient comes for revision.
I told you, I say, look, I did about 2,000 extrarticular from 77 to 85, 2,000, okay? I know extrarticular real well. I probably know more than most people because I did it. Then I do the intrarticular and then do less and less and less and less. So I know exactly how to do it. There's no problem. Lemieux, I work with Lemieux. I went to France to see him. Very good guy. But don't do it. Now, if I'm doing extrarticular, I would do a Lemieux kind of operation because it's cheap. Use IT. The IT band is wrong. Don't do the ALL. AL is a waste of money. It's you cost your graft, cost devices, and make the company very wealthy. Why you want to rob Paul to pay Peter? Why do you want to put an intrarticular part of the ACL to outside? So the extrarticular, I do say, like I say, 3% extrarticular when it's indicated. I do not want to do things not indicated. Okay? I mean, it's a value base. I mean, if you're going to do ACL the best you can, like I told you, you don't need to do it most of the time. Okay? I know Andy Williams, I know Get Good, they all want to do it, okay? I know all of them. They're very good people too, by the way. Very good people. They don't even measure insertion site. Why don't you measure insertion site first before you do anything, okay?
So Freddie, what are these indications for doing these extra articular denotices? What are the absolute indications where along with ACL you will?
There's an IT band compromise. And also if I really examine the patient, really unstable, and I did everything I can. I just revised the guy 10 years later. I did everything I can. I don't know why, okay? But I really know the size, insertion site, everything. So if you're going to do a hamstring, your hamstring was tiny, and you don't have enough hamstring strength, and you're unstable, then I can tell you your hamstring is unstable. In that case, I probably won't do a hamstring. Are you a quad tendon? Maybe I know the size, okay? So I would change. I know I want to give 50 to 80%, more like 70% of the time. So until people start measuring, now, by the way, Get Good and those people are working with us, and they're going to start measuring the size of insertion site before they conclude. They can go, I do some hamstring and some unstable, but how big the hamstring are? How big insertion site? They use 8 as a number. I told you, I did a 6 millimeters. Some are so small, you don't need to do a big one. Okay, so unless how heavy you weigh, what shirt you going to size? Are you going to wear my shirt, all of you? Freddie Fu shirt, one size fit all? No, you're going to wear your own shirt. Your wife going to go to the same store. Your wife will kill you if you buy the same dress, every one of you, okay?
But Freddie, we are being taught every time that if the graft is thin, it is 6, 7, you add an internal brace because collagen will stretch out and you will lose your graft. I mean,
internal brace, no, please don't do that. Okay.
Okay.
Internal brace is a waste of money. We did it 80 years ago. Okay, I did some too, and it doesn't work. I did about 200 artificial ligament.
Freddie, while
value based, come on, value based. If company want to pay you to do things, that's fine. Okay, why do you want to waste money on a patient? Okay, I don't look at my result. 5% failure, 15 years, 450 patient, level 1 study, randomized trial. I don't know what you want. Okay. I mean, you give $1,000 in the knee. I don't have to do any of those. I'll just measure the size. Like you're gonna hire a carpenter. You want them to measure your size before they fix it, okay?
Freddie, if you have planned a double bundle in a case, what is the minimum graft diameter which you accept, whether for a AM or a PL, or it is based on the footprint only?
Yeah, we look at a footprint. Hopefully, I can get a 6 to 8 or something like that, you know. But I know the Japanese do small one, to like 4.5 and 6. But if it's so small, I would do a single bundle. You understand? I mean, just I don't want to be so small, you know. I mean, technically, I'm okay. I'm not a genius surgeon, by the way. I mean, technically, I'm good, but I'm not like incredible, you know, like God's hand. Okay, so it's so small. I would like to do a single bundle. It is small enough, okay? So in other words, if the insertion is not that big, it's big enough, then I do a 6, 8. It's easy, it's fine, okay? You understand?
There is a question here, Freddie. In one of your slides, you showed a patient which has got a narrow notch and the diameter of the footprint is less, but the length of footprint is more. So would you change your...
Yeah, sometimes I do over the top. Instead of drilling holes, don't drill holes. Do over the top, okay? And I revise many patients that way too. I revise many patients that way, okay? I revise many patients that way because over the top is a device, is an operation done long time ago, but it's a bad reputation. But we do revision. I have done, look, I'm gonna tell you a story. I have a girl come to me almost 15 years ago from New Jersey. And the patient had a BTB done by a very good surgeon, trained in Cleveland Clinic. And she can get a knee straight. If you look at the CAT scan, the BTB occupied the whole notch. There's no room. So I took the ACL out, get a motion back, and do it over the top. And when she turned the outer side, I just did the over the top without even drilling a hole. Now, interestingly, 4 years later, her younger sister turned the ACL, but her notch is much bigger than her, so I do a drill hole, and no problem. Individualize every cases. Perfect. Then you will fix it. There's a problem. I'm going to tell you another one. I have a case from HSS. Come to see me. Okay. So again, same idea. No wrong. And the patient was told she has infection. She failed 2 times. They never culture anything. She was on an IV antibiotic for 6 weeks. I look at the notch, it's only 12 height. I do over the top. She was fine. She was like 6, 7 years out. Zero problem. I'm just telling you, you just look at anatomy, address with the patient, and you fix it. And most of the time it works, okay? Look, this is why I say it's cheap. I don't have to do all this crazy thing, okay? It works, okay? Look at what nature provides for you and try to fix it wherever it is. This is very simple, that way. Yeah.
You said, Freddie, that even healing is individualized. I mean, somebody would heal at 3 months, somebody at 6 months. So how do you
because, yeah, you're right. I mean,
is your MRI based, is your rehab based on MRI?
I don't know if they heal, but they can play, you know? I mean, they're so strong, you know? They're genius. Like, you know, is he playing? Is Pollock still playing in India? Is he still playing? Pollock, Color. Yeah. The cricket guy, is he still there in Mumbai?
Yeah.
He's still playing?
Yeah, he's still playing.
IPL has been postponed otherwise.
In 3 months. I mean, it's incredible. And Zlatan come in 7 months. Look, IPL come back early, but they're exceptional. And this is what people will advertise. Oh, they got internal bracing, they repair, they come back in 3 months. Come on. I mean, I can advertise Pollock. I don't advertise it. I say this exhibition you should not follow because he is a superhuman being, a genius, you know, professional player. They have incredible muscle power and healing power compared to a 15 years old high school kid that are weak and not strong, okay? So this is, unlike other industrial speaker, all you have to do, repair, internal bracing, all the thing. Then you can go, come on, this is not true, okay? I don't, look, I'm not a consultant for any company. I haven't received $0 from any company since I started. I can speak for my mind. I can speak exactly what I'm telling you without being compromised in any way, okay? Zero.
Do you change your graft option depending upon the sport which an athlete comes to you and his hyperlaxity situation?
Well, the thing is, remember I told you that case 6 millimeter size. So people go, just do the right anatomy. It'll get back the north side. It'll get back to minus 15. You know, I'm gonna tell you, nobody gets back to minus 15 degree. I never seen one in my life. I was able to take a chance on myself, my belief that this is the right thing to do. She's a 6 millimeter insertion site graft because it's gonna occupy 80% of the insertion site. And I did it. If I put an 8 millimeter in, she will never get back to minus 15, never. And she will get a much high failure rate, okay? So believe what God gave you. Okay, believe, okay? And this is almighty, okay? Or you can believe in Trump, Mr. Trump. He doesn't believe in all those pollution thing, okay? He destroy everything, it's okay, you know? All right? The virus from, you know, horrible place, what it is, okay? It's a natural thing. We're gonna fight the virus together, okay? The whole world, okay?
Freddie, if a 45-year male comes to you for a primary ACL and he has got a varus deformity also, would you like to correct it in the same sitting, or in the first sitting you will just do an ACL?
How are we going to discuss it? Sometimes if you want to, I mean, depends what is the symptoms. You know, the symptoms more pain and instability. Now, I know that if you're going to correct the varus, you know, sometimes you can correct instability too. So you can do, depends, you know, depends on how much arthritic changes it is. Now, in the 90s, I used to do everything together. But as I get older, I'm a little wiser. In fact, I did a bilateral meniscus transplant, an ACL, and an osteotomy all together at one time. Totally crazy. Probably should never done it. Okay, I mean, I used to do all those things. Okay, you correct everything, you know, but it's not. You have to think of the other knee. You know, my God, I mean, the other knee won't be the same. You know, balance and things like that. So again, sometimes it's okay to let it go a little bit. For example, once a time I have a patient with an ACL, PCL, and MCL tear. So I let the PCL and MCL heal. And they did, and I did ACL, okay? So maybe you say, well, let's do the multi-ligament. Sometimes you can wait. You can wait a little bit, you know, it's okay to wait, okay? So again, for the osteotomy, you can just do one part and then wait till, depends on, so now of course, you're a professional athlete, you cannot wait maybe. The professional athlete usually will not come back with an osteotomy anyway, so.
Right.
Perfect, I think I don't have any more questions. There are a couple of surgeons in the panel. So, Rajiv, Ranjit, Pratik, if anybody wants to ask some questions. Yeah, Pratik, please.
Yeah, Dr. Fu, excellent talk as usual. Just wanted to find out, you said there was individualized knee with different bony morphology and different sizes. So in what your preference is for somebody who has a different bony morphology is more important, or the knot size, or the ACL size, the footprint? What do you take as your primary factor, or you factor all of them in your usual day-to-day practice? What is the factor that you take?
Well, I think what you can do this, you can insert the insertion site. You also use a ruler, use 3 portals, 1, 2, 3. Why 3 portals? Because the central portal allows you to measure the insertion site and the north side beautifully. If you use a ruler on the lateral medial side, you cannot do that, okay? So if you do that, that will give you some idea. Now, of course, in the future, we'll have better ideas about 3-dimensional morphology, which I think many people are working on right now. If you look at the paper, you have different centers now looking at the 3-dimensional motion, things like that. But it's going to take a long way to come, okay? But essentially, right now, you can look at the insertion site size, both the femoral and tibial side, and you look at the north sides, and this is what we do. And with that, you know, understanding, then we can try to pick the graph over the top, you know, double bundle, single bundle. And many times I do not take the graph. I would measure first before I even decide what to do, okay? It takes a little bit longer, but it's gonna be better for the patient, okay? For example, sometimes you don't know if your remnant preservation. or you can do a one bundle thing. So you do remnant preservation, you probably don't need a quad tendon. You understand? You probably can use a hamstring, for example. So those are all the things we have to look inside, measure it before we decide. So far, we do not have a good three-dimensional, thing of. So one day, maybe before I retire or I die, maybe one day you can look at the knee and do a CAT scan or MRI 3D, and you can predict the size of the ACL insertion size. I really think this is something that is going to be in the next 20 years, 30 years, it's going to come, okay? Because you can really see by looking at the morphology of the bone, then you can predict how big the ACL is and everything else. You need, for example, do you need the ALL, for example, do you need the extraarticular? Another, question about it right there. Yeah.
Yeah. So you do all decide intraoperatively. Pre-operatively, you just have a little idea, then you do it all intraoperatively, changing the part size
all the
and
time.
everything.
So I do pre-op in every case. It's ultrasound, MRI measurement, everything, and then it's very obvious. Then I'll go ahead and take the graft. Okay. So if it's a very big insertion site, complete tear, no repair, then I'm going to do. But if it is not questionable, then I would do intra-op measurement, look at it, and compare to the pre-op measurement. It's not that hard, I'm telling you. It's really not that hard to do, okay? So, good, thank you.
Freddie, you said everything is biology. Are you working something on orthobiologics to augment healing as well?
Yeah, I have used fibrin clot, which is very cheap, I'm cheap, I'm a very cheap guy, okay? Some curry. Just give me some go curry, and this is all I need, okay, when I come to your country. Good curry with bone, okay? Same. I just use fibrin clot. People use all kinds of stem cells. It's crazy. Don't do it. It's expensive, okay? Use the cheapest thing. I just, 50 cc of blood, put in a thing, you got it, and you have all your stem cells, all your growth factor. You stick it. In fact, if you do repair, this is what you do, no matrix. Put the sutures in, put the fibrin clot, just put it up. I put fibrin clot between the bundle. I put fibrin clot inside the hamstring graft too, okay? I store it inside fibrin clot. It's all, I did go studies. It all helps to healing. You don't need all those biological things, okay? You don't. In America, they do it. They charge $5,000 more, for stem cells, and it's totally insane. PRP and those things. I'm cheap. I don't cost the patient any money, okay?
Yeah, that's quite interesting, actually.
Freddie, hello.
Yeah.
Hello.
Now, I'm going to go pretty soon. I have a meeting coming up, okay?
Yeah, so that's the last question, Ranjit. I think you can please.
Yeah, last question.
Yeah, and then
Freddie,
Deepak can conclude.
Yeah, Freddie, what is your take on hyperlax individuals? Because again, you believe on your double bundle morphology, or many of us doing the extra-articular procedure to protect our graft. You believe in that?
Yeah, but if you do extra-articular, you're gonna restrain the motion. So it's nothing. The hyperlaxity to extra-articular, there's no correlation. The correlation between I told you, is the bone morphology in the ligament. This is what it costs. If the extra-articular part, you're gonna do it, the extra-articular will limit your motion. In fact, if you limit your motion, you can have increased repair rate by 20%, okay? So, like I told you, you just restore the anatomy. Unless something wrong, if the patient have allodental syndrome or some crazy thing, then it's thing. But if the patient have a normal looking patient like you, I'm not gonna do all this crazy thing on you. I can do anything I want, okay? But do the anatomy first. So if the patient have the IT pins intact on the ultrasound, no tear, I'm not gonna do anything about it. If it's normal. Why you want to change something normal to be abnormal? And so just restore the basic anatomy, just like I told you, I do a 6mm graft in the patient and she is fine. So I don't think anybody in the world do a 6mm graft on an adult. I'm the only one, I think, okay, that ever done it, because I make the graft smaller to fit her, okay, and it works. So this is only one case I know, but it really tests my theory. It's not fun size at all. It's a bell curve. It's a bell curve. You want to do it in the middle, or you do the extremes. If you're going to take up all the extreme, then you're taking about 10-15% of your problem right there. You don't have to waste money, waste all those things. Just do the best ACL you can first. Then you can do anything you want. You can do internal bracing. You can do extraticular, all you want. I don't care. I can do all of those things too, but I don't do it. Okay, most of it. I gotta go. I have a meeting.
Thank you, Freddie. That was a very mesmerizing interaction.
Yeah. So we have a good turnout today. You have a good
Samanta.
Thank you.
Okay,
Yes.
I appreciate that. We'll do it again. We can do it again on ALL. Let's do one on ALL.
Sure. We'll fix up with you.
Because ALL is a hot topic, and I think
Yeah,
we would need it. Samantha,
Yeah,
if you
we'll
can-
do it. We'll do it. Phil, I have a beautiful talks, and you'll see it. Okay, you love it.
We shall be in touch with you for that.
Yeah. I'll do it in a few weeks. Seriously.
Okay.
All right, you want to do it?
Okay, I think we have answered most of the questions. And Freddie, I am the secretary of the Indian Arthroscopy Association, and we are always been listening to your lectures for so many years, and really appreciate your passionate lecture. It's not the way you teach us, but you are really passionate about the ACL. We have learned many things from you for so many years. Thank you again from
No, we should be all personate. This is human being. We have to be patient towards our patient. Just don't do something. No, we have to love our patient. Okay, patient first. Okay, patient first.
first, obviously. Patient first.
Bye-bye.
Thank you.
Bye.
Thank you.
Bye.
Bye.
Okay. Are we offline?
No, sir.
You're
Vote of thanks.
Okay. I think we must thank Deepak Chaudhary for
अरे यार
arranging
मन्नो की
this.
thank कर रहे हो.
No, sir. It is.
बड़ा बंदा, या तो मैं
Because
प्राय
we need, tomorrow we have an interesting webinar. It's an innovative video technique session. I think we are doing it in 2 or 3 parts. We are inviting people who have done some innovative work in new techniques in arthroscopy, and we want it to be shared among our fraternity so that we learn new techniques of doing the same thing and how it has changed the way outcome is happening. It is at 6 p.m. tomorrow. The web link is same. You can log into the IAS YouTube channel and have a look at this webinar. We have 3 international speakers, including Bancha, who is our close friend from Thailand. Dr. Ziad is president of the Arthroscopy Society of Jordan. He's joining in. And Amit Joshi is secretary of the Nepal Arthroscopy Society. He's joining in. So let us meet tomorrow to a new innovative video session of arthroscopy. Till then, take care. Bye-bye.